Hello, everyone. Welcome to this talk on neuroimaging and psychedelics, the past, present, and future, it's titled. So, context this, the modern phase of development of psychedelic treatments has occurred along with the wider use of advanced human neuroscientific research methods like neuroimaging that can help the assessment of drug and therapy effects with greater precision and quantification than any previous steps forward in psychiatric drug development. And neuroimaging has played a key role in early clinical trials with psychedelics, but there are many questions left unanswered as we're going to get into today, and I'm going to just get straight into it. So I'm going to introduce our panel. To my left, we've got Dr. Beata Godlewska, clinical research and honorary consultant psychiatrist at Oxford University's Department of Psychology. To her left, we've got Matthew Wall, head of MRI applications at Invicro, a database drug development platform. And to his left, Dr. Chris Timmermann, psychedelic research clinician at Imperial College London. So it's a quick intro to this. I'm just going to tell a quick anecdote. I interviewed Amanda Fielden a few years ago of Beckley SciTech about her incredible journey of bringing psychedelic research into the mainstream. And she told this story about a collaboration between her foundation, Beckley, and Imperial College London, completing the first ever bit of research on neuroimaging to show the effects of LSD on the brain. And it was a fascinating interview with Amanda. She's been called the crackpot countess at times. She's a colourful character, but she told me that I realised in the late 60s that the only way through the ever-increasing taboo was the very best science, and that the new religion was science, and one had to prove through that new religion that these compounds were factually advantageous. So when brain imaging evolved, I suddenly realised I have to make a scientific foundation and use brain imaging because it can give you a visual perspective that you can't deny. So perhaps, a good intro to why neuroimaging is important to this area of clinical research. So Matt, tell us, how much has neuroimaging, in your view, had an effect on this incredible journey of bringing psychedelics into the clinical mainstream?
I think it's had a really big effect. So, the early studies on psychedelics that were done by the guys at Imperial, including Chris, and some of the early studies in the US, they all used functional MRI alongside the kind of clinical measures that they were using. And I think one of the things that's really driven the public awareness and acceptance of psychedelics has been the images that have come out of that research. I mean, that really famous image of the two circles, you know what I'm talking about? It's on the inside covers of Michael Pollan's book, which was from one of the early psilocybin studies. That image has been everywhere.
That's the one that shows the brain lighting up and more connections.
Exactly, more connections under psilocybin than under placebo. And it's results like that have I think had a huge impact. And I think we've got this opportunity with this current wave of psychedelic research to develop the clinical side of things and look at the science, the brain imaging side of things in lockstep, which we've never had before with any other kind of psychiatric drugs. I mean, the last major class of psychiatric drugs, the SSRIs, came along from the mid-80s, We just didn't have these tools then. And this is really the first opportunity. I mean, I know they're not new drugs, but we've got this new impetus behind developing these drugs for clinical usage, and we've got the tools to look at them in the right way as well. So I think it's really exciting.
Yeah, and that's a good place to bring you in, Beata, isn't it?
And I thought I would add as well that the fact that we can use neuroimaging, it's got a dual role. So one is drug development, but also destigmatizing depression. As it's still quite often perceived as something that is not great to have a talk about, unfortunately. And through using neuroimaging, we can actually look at it. This is a disease of the brain. It actually happens in the brain, and drugs like psychedelics can help it.
Yeah, it sort of challenges that previous, like my parents' generation. My dad will just be like, get on with it, stiff upper lip. And with neuroimaging, you can show, no, there is actually something going on differently in someone's brain.
And you wouldn't say the same thing to somebody who just had a stroke, right?
Right, exactly.
And so, the brain as well.
Yeah, so it also works on that other side of proving the need for these treatments. But tell us about some of your work, Beata, with SSRIs and neuroimaging and how that can inform as we go forward with these clinical trials of psychedelics.
Yeah, so with my group, we're trying to understand how those drugs that Matt mentioned, SSRIs, so we've had them for like 30, 40 years, but actually we don't know fully how they work. So neuroimaging really helps us to understand what happens at the brain level when we start taking the drugs. So what we do, we are using them for a few days or a few weeks, and we are trying what changes in the brain and what can predict the response to treatments. Because it's a known fact that not everybody will respond to medication. Some people will, a lot will, but some of them won't. And it would be really nice to know why it happens, but also to translate into clinical markers. So say we can do a brain scan, we can say you go on this drug, you don't go on this one because it doesn't make sense, you're just wasting time. We're not there yet, but we are trying to understand what happens. So in our work, we could see that changes in the brain occur very early on in treatment. So actually after a few days, 7 days, we already see that the areas that are different in their function, people who have depression, and this dysfunction actually lays at the basis of the symptom development, they turn back to the level of function of healthy people. And then we need a little bit of time for actually this effect to translate into a clinical change, so for people to start better. So this is what we could see very nicely at the level of those nice pictures that Matt described.
So there's a bit of a lag, is there, between the changes in the physiology and what you see in the neuroimaging to when symptoms change?
That's true. We know that actually changes happen very quickly. So when we take one dose of an SSRI, we already have effect on the gene expression at the biological markers in the brain, and we can see it on the pictures. But we have to wait another, to have I would say, full clinical response, we have to wait 4, 5, 6 weeks. And something needs to happen in between. We've got theories about it, obviously.
Yeah, super interesting. And I guess too early to explain exactly what's going on there. But Chris, coming to you, I guess what Beata just raised shows that, the neuroimaging can help us deal with the fact that not one size fits all treatment works for everyone, and different people will respond differently to different drugs. So how, in your research, has neuroimaging showed you the diversity of the way people respond to psychedelics like DMT, for instance?
Yeah, I think it's intriguing when one thinks about how psychedelics enter into the picture of brain response and clinical outcomes. So we see a lot of variability in the response to psychedelics in terms of the experience that people have, and also at the level of brain activity. We see an overwhelming effect, a general sort of effect, but then the specifics of what's happening in that drug experience in relationship to how the brain is changing is extremely varied on certain aspects. And I think it's intriguing to think what's happening right now in the field of psychedelic research in terms of what is the mechanism driving these changes. So one side of it is, it's neuroplasticity, it's just a brain change that will happen automatically. And the other view is that, no, you need a certain kind of experience to achieve certain clinical outcomes. And I think that, at the basis of that discussion, you have, age-old discussions about, Descartes and the mind-body problem and all these sort of fundamental questions about the mind and the body. And I think it's just intriguing how we're going to attack this puzzle right now in neuroimaging research, and how psychedelics do present an opportunity for us to try to understand that variability at the level of experience, at the level of brain activity, so that we can then target personalized interventions, target personalized forms of treatment that not just involve, for example, a specific dose of a psychedelic, but also the way that you administer, and also, very importantly, the psychological support, so that both of those things combined, generate a desirable sort of outcome that fits the profile of that person.
And you raised the point that often, the level of experience impacts the clinical outcome, and that's been quite well proven in a number of studies, I think. But is that something, can you map a profound experience onto brain activity in your experience when someone's had something, really ontologically sort of, that shakes them in a profound way? Can you see that in brain imaging in your experience?
We've got some evidence suggesting that there are, specific kind of changes of, specific brain systems or specific brain areas becoming hyper-connected with the rest of the brain. And that somehow correlating, for example, this was studies that for example, Robin Carhart-Harris did, in which they showed that specific brain regions that become hyperconnected are related to the degree of ego dissolution. So you can think of an extreme ego dissolution experience as a form of a profound experience that is related to the mystical experience. But I do think that there's still massive amounts of work to be done in that regard, and how we can actually generate a meaningful bridge between these meaningful experiences, the kind of outcomes that everyone here is interested in, and how we administer the drugs.
Matt, do you want to come in?
Yeah, I think that's really a key point. So this bridge between the molecular effects, the functional effects, and the clinical effects. There's still, I don't think there's been any data yet where people have scanned somebody, looked at their brain when they're having the acute experience, and then done some kind of follow-up scan sometime later to look at longer-term clinical effects. So there's been studies that have looked at healthy subjects mostly, looking at the acute effects. And there are studies that have looked at clinical subjects, depressed patients, that have scanned them before and after treatment. But I think to really nail this, this mechanism whereby, as Chris was saying, we're not sure if the quality of the experience that people have relates to the later clinical effects or not. To really nail that question, I think we need to study people, patients probably, at baseline while they're having the acute experience, and then try and relate some features that we see in the brain while they're having that acute experience to other brain measures that we get later on that relate more to the clinical effects.
Mm-hmm. Yeah, go on.
I can add to it. So in our research, we are also trying to understand why there is this gap between what we can see clearly happens in the brain and actually when people respond to treatment, because it can be a delay of a few weeks. And one of the ideas is that actually those changes in the brain need to have a chance to interact with the world, really, environment. So it's there, we've got the baseline for it, so the brain is not overactive, it's not scared of everything. This kind of, there's something that we call a negative bias, how we see the world, it's changed. So, in depression people see everything in darker goggles, like everything is darker, less pleasant. This changes, but then those changes have to have almost like I would say, a chance to prove themselves to us so that we can start feeling better. And that's one of the ideas why we have this gap. So people have to go out there and interact with the others, especially with other humans, and actually almost relearn and recreate new associations in the brain. This is something that's quite difficult to test scientifically, but there were studies showing, for example, that people who were treated with antidepressants, the predictive value of a brain scan was only in those people who actually they perceived the level of support they were getting as very positive. So there was something happening to them at this social, psychological level as well. And this, as Chris said, this may be the case with psychedelics as well. And this is something we would be very interested in.
Yeah, I mean, just to compliment, I find that so fascinating. We were speaking about it just outside, and I think it's just so fascinating because when one thinks about the conventional way of doing psychiatric medicine, you just prescribe the medicine and just wait for some sort of fundamental brain mechanisms to switch, and then that having some form of black box downstream effect that would relate into the way that they appraise their mental state and how well they are and so on. And it's almost like the way that I think psychedelic therapy or psychedelic medicine has been framed in recent times. I mean, not just in recent times, but it has come out more strongly, I think, in the mainstream, that it is this combo of therapy and the drug effect, almost as let's say kind of like a package of what you were just mentioning before, right? So you have that immediate physiological effect, and then the learning that's happening in a social context is happening in that social context in the therapy session between the therapist and the patient. So it's kind of like, it's just very intriguing also from the point of view of how psychedelics act and how we know that psychedelics relate the experiential component with the context surrounding that experience. So it almost calls upon having this sort of integrated I don't want to say holistic because it's close to esoteric sort of associations, but a more kind of like biopsychosocial way of dealing with mental health.
Yeah.
I think this is actually the direction of changes. We stop seeing, like, there used to be this view that psychiatry with drugs and biology was on one side, and then psychology with, emotional concepts was on the other side. And luckily, this gap is changing. I think this is very much thanks to neuroimaging studies showing that those emotional concepts, cognitive concepts, they are rooted in the brain, and through the change in the brain function, the amygdala that starts being overactive goes back to a normal activity level. We stop seeing things as negative, which was very psychological 20 years ago. And I think this is a good direction of change. That's how we should see ourselves, as the whole thing, body and whatever you call it, the soul or emotion.
Yeah, but I suppose this gap that you describe about the time it takes between the physiological changes we see in neuroimaging and then perhaps, as you say, having to interact with the world draws out, I guess, the limitations in a way that neuroimaging doesn't explain the whole picture. And I kind of wanted to ask you a bit about this, Chris, and, someone who researches DMT, kind of, a psychedelic that's known for taking people to another realm and all these commonalities of experience like machine elves and, basically shaking people's worldview of dimensions and their place in the world. Can that ever really be summed up in neuroimaging, do you think? Or is it just a tool to help us see what the I guess, the effects and the uses can be? Will it ever really allow us to hook in onto that experience?
I think it will allow us to I think we can get much better at characterizing what are the biological facets of that experience. But at a very fundamental level, I think experience is its own register and has its own value. And I don't think we can reduce experience fundamentally to any form of brain activity. I have a bit of a conviction and a kind of like a dog in the game that I think we should develop ways of doing science about experience. We should improve the way that we incorporate experience into, ways that are reproducible in scientific understanding so that we can apply the rigor of science to experience. And if you ask me about the crisis in mental health that we have right now, it's very much related to that lack, to that gap of understanding. What is a mental health disorder and how does it relate fundamentally to the experience that we have in the world, which is really the primary register to any sort of interaction that we have out there. So it's kind of like a yes and no answer, I guess.
Yeah, but I think, it speaks to the fact that neuroimaging is never going to tell the whole story, but can be very useful, as we say, in making cases for how psychedelics can be positive. So coming to you, Matt, and, as someone who works on a database drug development platform, what other kinds of neuroimaging techniques beyond MMRI, like what's the next phase of this?
So the place where I work, we do a lot of MRI and we do a lot of PET as well, positron emission tomography, which is a molecular imaging technique. And I think there's a lot of scope there. So, PET is very useful in general drug development. And PET can basically tell you two things. It can tell you, first of all, if your new drug actually gets into the brain, if it gets past the blood-brain barrier. Maybe not so helpful for psychedelics because we're pretty sure they get into the brain. But PET can also tell you exactly how strong an effect your drug is having at the particular receptors that it's binding to, the binding potential of that drug. And some of that work has been done with the classic psychedelics, LSD, psilocybin, DMT. So we know, for instance, that psilocybin has a kind of medium affinity for the 5-HT2A receptor. Mescaline has a very low affinity. LSD has a very high affinity. It binds very strongly. But I think that is potentially going to be a really useful method as people start developing what some people are calling like second-generation psychedelics, so novel molecules which bind to the 5-HT2A receptor or different analogues of the classics. I think most of these things are at quite an early stage, but I think once people develop those a bit more, we're going to want to start doing that kind of testing in humans and just figuring out, okay, in order to hit 80% occupancy of the 5-HT2A receptor. What dose do I need to give? That kind of thing.
Yeah, so expand on that a bit more in terms of novel psychedelics, in that I guess that granular detail about receptor binding strength, that can allow us to focus how we build a psychedelic to act on different receptors, which hopefully we'll be able to map onto different mental health issues. Is that the idea?
Yeah, possibly. I mean, you can look at lots of different receptors with PET. So, I mean, and psychedelics do have a more complex pharmacology than just the 5-HT2A receptor. So, I mean, LSD in particular has a really complex set of effects at dopamine receptors and things like that. So, yeah, it's possible that we might end up with compounds which have, which we can index in terms of effects at different receptors, and maybe they might be more suited for certain conditions or not. Yeah.
And yeah, I mean, I guess on an experiential level, one thing I've heard from speaking to companies in this space is that some people have the theory that in the case of psilocybin, having natural psilocybin and all of the kind of compounds around the psilocybin in the mushroom, for instance, will give a different effect. Is that something that we've been able to see with imaging?
That's quite difficult. I mean, so yeah, people talk about these entourage effects. They talk about it a lot with psilocybin, and they talk about it particularly with cannabis as well, because there's lots of different cannabinoids in natural cannabis apart from THC. With psilocybin and natural versus synthetic, I'm not sure. I mean, it's possible. I mean, to be honest, we don't even know what these other chemicals that people talk about as being important are. I don't think that's really been identified.
Okay, so that's a level of granularity that we haven't got to yet.
Yeah, I don't think so.
Yeah.
But I think also, like, if we want to use a substance as a medication, we need to be able to control it. So we need a purer substance. So we possibly wouldn't like to be giving like a mix of different medications with slightly unknown interactions. And yes, maybe the experiential level will be better, but it doesn't mean it will be better for a condition that we are trying to treat.
Yeah, interesting. And I guess, opinions would be split on that. And some people would say that, giving someone natural psilocybin, might be safer in some ways. It's got a lot of historic, data about it being safe. But I suppose, yeah, from a purely sort of, scientific perspective.
Yeah, and I guess also, like, it's not just scientific. Like, when we do clinical studies, we actually test a certain substance for safety. So I guess
you'd be more comfortable with a pure psilocybin
using it in people, because
there's a lot of natural things that will kill you as well. Just because it's natural doesn't mean it's good.
Yeah, no, I'm not advocating for just eating loads of natural psilocybin for no reason. But
you can.
You can. But anyway, so let's move on to how this can enter the clinical sort of context a bit more. Beata, do you think that neuroimaging can help in the way that clinicians deal with on a patient-to-clinician basis rather than just at the research level as well?
We're really hoping for this, and this is really why why we do all those studies. So obviously we want to understand, but really what we want to have as a tool is a test. Like we take blood and we can say, oh, you need to take thyroxine or not, right? So you would like to do the test, the brain scan, and actually tell the person, go for a citalopram, go for venlafaxine, go for psilocybin, because this is the drug that will help you. For now, this is still trial and error approach, and we try different drugs till we arrive to the one that will work for a given person. So that's the hope. It hasn't realized itself yet in the practical terms, and I guess there's a lot of obstacles to it. So it's not at the level yet that we know that we do the test, we see certain results, and we can translate it into the individual level. I guess then NHS won't adopt it because it becomes too expensive. So there's quite a lot of hoops that we have to jump through. But I think this is one direction that drives a lot of people who work on this kind of studies, not just to know what happens, but also how we can help actual patients.
And coming to you, Chris, what do you think neuroimaging can help with, the wider implications of mental health care with psychedelics in mind? What can this bring to the wider mental health community as we try and put these treatments into the real world?
Yeah, what comes to mind is, there's a theory that why psychedelics didn't work in the 60s. One theory is that, the UN kind of prohibited them, and therefore, they became illegal, they became too much of a chaotic element out there in society, changing the culture and so on. The other theory is that pharma companies deemed psychedelics to be way too unpredictable. So the psychological response for them would be so unpredictable, so hard to contain, and therefore also the clinical outcomes would be very varied eventually to some extent, as well as tailoring the right clinical context and therapeutic sort of context for that experience to unfold to be safe and effective. So I think, the obvious thing that comes to mind is how can we harness simple ways of doing neuroimaging, for example, EEG, just have a cap, electrode, and somehow build in the usage of EEG to profile the kind of response that individual can have and tailor an immediate sort of dose and way of giving that drug. So for example, we're starting to do some experiments with DMT, continuous infusions of DMT. And regardless of the fact that we know that we can now extend that DMT experience over time in a fairly predictable way, it provides a perspective that you can have a malleable psychedelic experience according to the needs of that individual. So I think if we harness something of simple neuroimaging tools that are practical to use, easy to set up, to then tailor that session that will happen, I think that's where it lies, reducing the amount of error that can come out of that experience.
Yeah, and giving some level of explainability to the different way people can respond and giving some clinical kind of answers to that. We haven't really touched that much on EEG. How much are you guys using that, Matt, in terms of adding more data points?
Chris is the expert, really. We're talking to somebody at the moment about a possible project where we're doing combined fMRI and EEG. So that's people wired up to an EEG machine and in the MRI scanner at the same time. That's at an early stage, though. I think EEG is cool and possibly really good for patient studies. With certain populations where you don't want to put them in a great big horrible machine like an MRI scanner. It's much less intrusive. There's pros and cons of doing EEG and other things, but getting all these sources of data and putting them together, I think, is the real key. So getting the molecular level information from PET, getting the kind of functional stuff from fMRI and EEG, and getting that, putting those bridges together between the molecular level, the functional level, and the clinical level, looking for those mechanisms that connect those kind of domains, if you like, I think is really key. So yeah, I mean, any technique is a good technique, I think, in trying to figure out those linkages.
Yeah, and Beata, how have you seen that as these techniques have come more and more into psychedelic research? Do you find that, in your field of research, having looked a lot at, let's say, more traditional drugs like SSRIs, do you see stigma and taboo breaking down as a result of these techniques, or do we still have a long way to go there from your perspective?
I think there's been a lot done to decrease the stigma. I think it is changing. It's not only because of neuroimaging studies. There's a lot done through talking and reaching out to the public, through media, and actually talking about depression. So it stops being something that you have to hide. But I think all those studies really add to it, because we really can show people that this happens to our body. And there is sometimes that there is no impact of our will on it. It's not that I can do it, I can't do it. As I said, you wouldn't tell somebody with a stroke, just get up and move. And it's the same if your brain doesn't function the way it should function. You can't simply just decide to get over something. So I think that there's a big tool in decreasing the stigma. I think it is changing. I think it is a more acceptable condition. It's culturally influenced. I can see it very much in the clinic. It depends where somebody comes from, what are their beliefs about the word. They will take medication, they won't take medication. I've seen some really depressed people who say, I won't take medications because my belief is this depends on me. And luckily, more and more people who actually talk about depression come for help. And in a way, I think research studies, they help because people sometimes feel more comfortable to come to us for help and to help us actually to develop research. And it changes things.
And do you think that within the sort of the mental health research community itself, that stigma is breaking down from what you see, or do you still see some more traditional views in some of your
I think
colleagues?
people are more and more interested. We are all craving for new medications because we see like 30% of people with depression, they don't respond to any medications. So we are embracing ketamine, we are embracing psilocybin, and we are really quite curious about what can come out of it. As I mentioned, it's really important that the drugs are tested in a safe way, so they are then given to people. We can be sure that people don't get addicted, they don't go on bad trips, that nothing negative can happen to them. But it's really exciting, the development, that we actually may have new medications, as Matt said, after, 40 years, right?
I think one little point about maybe convincing clinicians about these treatments. So one of the big issues in clinical trials is the blinding problem, right? So it's very hard to double blind these drugs. People know when they've been given 25 milligrams of psilocybin compared to a placebo. And this is actually a point I've stolen from Robin. Sorry, Robin. But I think neuroimaging approaches give you an objective measure of drug effects. So you can look at the brain scans and go, well, placebos don't do that. The drugs are clearly having an effect over and above placebo based on the brain data. And I think that might help convince clinicians in particular.
Just want to give time, if anyone's got any questions, do raise a hand. I've just got a couple of minutes left, but if anyone has got questions for the audience, do let us know. If not, I've just got a final question for you, Chris, which is, we just touched on the sort of the clinical industry's demand for new drugs. And I just wonder, we've also talked about novel psychedelics and analogues, and I just wonder, how do you see this kind of pursuit of novel drugs? Sometimes that's done to get around a patent or to be able to create a patent. Do you think, is it a complicated picture, this desire to create new drugs in terms of, the economics of the pharma industry?
Hard for me to say. I'm not in drug development per se.
I guess, what do you make of, you studied DMT so much, what do you make of the, pursuit for analogues of that kind of thing?
Well, I think there's certainly exciting possibilities around novel drugs and novel compounds that have come out. I can think of psychedelic analogues that have been synthesized in the past, the 2C family, there's a range of possible dissociatives that can be also developed that can have clinical applications. I guess, I think it's a long-term game. I think when one thinks about potential analogs and the array of possibilities that we have now to develop into clinical applications, there's so much work to be done. There's so much work to be done on understanding the mechanisms of the therapy accompanying the drug action that can drive the benefits, how to formalize that whole thing. So it feels like, in terms of development of therapy, I would prioritize efforts over there. But in terms of interesting research on the mind, the development of novel drugs is a super fascinating field for sure.
Yeah, well, that's a whole other discussion, isn't it? Putting more time and effort into that therapy side of things and how that can be rolled out, which we don't have time for now. So give a big round of applause to our panel. Thank you very much.